All right.
There you go.
Well, I don't know about all of you, but today I thought, hey, it's Treatment Tuesday. And was so excited to be joining everyone again. We would like to once again thank our sponsor, Southpaw Enterprises. Mark, are you there? Would you just like to say hello? And we want to thank you again.
No, thank you. It's always great to be a part of this.
Well, great. Well, thank you for your support, and we hope that that everyone at Southpaw has been enjoying these sessions as much as we have. We've had really great feedback.
They're supposed to be tuning in tonight, so we'll see.
Oh, great. Well, hello, friends from Southpaw, as well as our therapy community around the world. We're glad to have you all with us. And as we have been moving along, Suzanne really has put together an amazing program. I'm just always in awe of her talent in this area of bringing together such wonderful topics and speakers. And so we've had a few sessions where we've had some different aspects of intervention around Ayres Sensory Integration. And tonight we're really excited to welcome a wonderful speaker, Gina Freeman. And in a minute, I'll also tell you about some of our panelists, but it's just such a pleasure to have you with us tonight, Gina. Gina
Thank you.
Is an occupational therapist at Children's Specialized Hospital in Toms River, New Jersey. Some of you might know that Children's Specialized Hospital has several locations. And she's been involved with so many projects. It's been really a pleasure to work with Gina and the team there over several studies that have examined the evidence for Ayres Sensory Integration under the leadership of Dr. Roseann Schaaf, our good friend at Thomas Jefferson University. And it's just been amazing to see you and the team growing and all you've been able to do to share this information. You've created staff training and a clinical setting curriculum. Every time we get to work with your therapist, we're really impressed with how you and the leaders there have really helped the therapist with their professional growth. So Gina's a supervisor of outpatient pediatric rehabilitation, and she's been instrumental in autism and feeding and upper extremity work and cerebral palsy. And we've been really lucky recently to work with Gina in her role as the clinical liaison for the New Jersey Autism Center of Excellence. And once again, she's using her leadership skills and expertise to share information about sensory integration in a really broad way. So I know you're all going to enjoy hearing from Gina and seeing her work, as I really think you're a master clinician, Gina. Every time I get to see you with a child, I'm just love watching you with the kids. You have such a great way of understanding them and supporting them and working through the process. So we'll get to hear from Gina in just a moment. We also want to introduce two panelists that we have with us who are comrades and well, I guess I could say partners in crime in a way with Gina. Dr. Joanne Hunt, who is the clinical lead of the Department of OT, and Patty Fowler, who's the staff occupational therapist, both of whom are also at Children's Specialized Hospital and have been with us through these studies as well. So we hope that you two will be chiming in. I know we'll probably come back around to ask you for some input about any words of wisdom about applying Ayres Sensory Integration in a hospital setting. So welcome to both Joanne and Patty. So I think, well, let's see, but right before we start, Gina, we just want to mention that we hope everyone can stay for we're just here together for an hour. We have some really great prizes, including donation from Southpaw, some equipment, and we also have an easy starter kit. So don't leave, we'll be raffling that at the end of the webinar. So with that, I'm going to stop sharing my screen and turn it over to you, Gina. And thank you again. We're just thrilled that you're here and so happy to see all of our friends from around the world who've joined us as well.
Excellent. Well, thank you so much for having me. And I am very blessed to be working with my partners in crime, Joanne and Patty, and our missing partner who's on vacation, Elke van Hooydonk. And it's our pleasure to be here and share our story and our journey in helping to build the evidence-based practice with Ayres Sensory Integration. We're super excited about all of it. This.
Nope, you're good. So just hit share and then go to PowerPoint.
Okay. So thank you again for the great introduction. And what I'd like to talk about tonight is really how we use Ayres Sensory Integration in the hospital setting, looking at the equipment, the infection control policies that we have, integrating shared split space, because we are very much a multidisciplinary practice. We share our space with speech therapists and physical therapists. We'd like to share also a lot of what we learned from participating in the RCT in conjunction with Thomas Jefferson University. And then I'd really like to go through a clinical case that also shows the DDDM process in our hospital setting with a child with autism, and just expand a little bit more on that in terms of how we are able to fine tune that clinical reasoning. So looking at how we just fine tune what we're doing. And then at the end, talk a little bit about our documentation. Okay, so first, equipment. So as you can see, Southpaw is inundated in our space. So we're incredibly grateful to Southpaw and all the equipment that we're able to order from them. And what I'd like to take a look at in this particular slide is some of the challenges that we had coming off of being closed down a bit from COVID-19. So if you look to the left of this picture, compared to the right of the picture, we did spend a little bit of time when we opened back up. We had to take out any of our equipment that was fabric. So we really, we didn't have our Lycra swing, we didn't have the Lycra tunnel. And we had to really make some adjustments because we instituted some extra cleaning processes when we reopened following the pandemic. So we adjusted our clinical space a little bit. We had to take some of the padding off of our Cloud 9s, and we had to do without a little bit of the equipment that we were so used to, but we made some adjustments and we were patient, and thankfully in the past couple of weeks, we were able to reintroduce those other pieces of equipment back into our space, which made us very happy. We were also very happy that Southpaw was able to produce quickly these substitutes for the carpets. So we quickly ordered them, and it made our space a lot more manageable from an infection control perspective. So in our hospital setting, we have particular products that we need to use in between every patient. These products require us to wipe everything down, get them wet with the product, and it takes an approximate minute or so for it to air dry before we could then use it with the next patient. So during the recent months, we've really upped that a bit, and it was great that Southpaw responded really well with helping us out managing some of that extra cleaning that we needed to do. That was a big, big hit for us. So that brings us to a conversation relative to a bit of a challenge that we have in getting the intensity up with some of the tactile exploration and the really child-directed exploration for that tactile system. So we do have some equipment. We get a lot of use out of these koosh balls. They're very cleanable and wipeable. We have these sponges and lots of other sort of tactile bins. We've gone far with these bean bags. And however, it's a little bit of a challenge for us in terms of how intense we could get going with the tactile system. It's always something that we're talking about in the staff office. We're always brainstorming new ideas on how we could have cleanable tactile exploration. So as we're talking, if anybody has great ideas, out there in the crowd and can snap it into the chat, it would be welcome. I'll be more than happy to share that information with everybody. Sometimes what we'll do to address this challenge is we'll incorporate a lot more tactile exploration into our home programs. In addition to that, we often will make individualized bins for our patients that have some of the less cleanable things in them, and we'll set them up as a single use for that particular patient. So we do our best to overcome this challenge, and we're constantly thinking and exploring different ways to incorporate the tactile system into our space and do it in a way that we could still maintain our infection control policies. So in this picture here, this is our gym in Toms River. And we're very lucky that we have a very large space to treat in. With that, it's a large space. There's often a lot of people, and we have many therapists at any particular time. And that has posed a little bit of an interesting situation relative to the pandemic and maintaining social distancing in our space, because that is definitely what we're tasked to do right now. So we have had to make a few adjustments. So in the past, we would have multiple occupational therapists working at the same time with speech and PT, and we would be in each other's space. We would share toys. We would take turns on a piece of equipment. And we just haven't been able to do that because of our social distancing situation. And it's been challenging. In the past, we were so excited to share and engage with the other people in the room. And now we have to be a little bit limited in allowing the kids to take turns, a little bit limited in having them share toys. And that's something that we're really sort of just going through and talking about it amongst ourselves to just see how we're going to handle that, see what words we're going to use to help the kids orient to the space and still do the child-directed sensory experience that we've all worked so hard to get to. So we've had to shift a little bit and maybe build from session to session rather than get some of what we would have previously gotten within one session. So we also, I'm sort of happy to say that at Children's Specialized, we continue to grow. We are opening 3 new facilities in the next couple of years. And in planning for our new space, we have allocated a large size room, but a closed off room. So it's not as much of an open scenario. In a few of the videos, you'll see where it's hard a little bit with some kids to, focus in on that child-directed scenario because we have a bit of an open space here. So we definitely planned for our future spaces. There's going to be panels in the ceiling that control noise. There's going to be excellent lighting. And we're going to have in each space a fairly large sensory motor room that has multiple hooks of suspension and lots of padding and enclosed space, so we could really expand that child-directed experience. So next, I would really like to share the journey that we took when we participated in the intervention study. So with Dr. Roseann Schaaf and her colleagues from Thomas Jefferson, we were able to do the treatment portion of this study, the intervention for sensory difficulties in children with autism. And just as a quick review of what we did, in this study, we had 17 children in the treatment group. We had 15 children in the control group. We did 30 sessions of therapy in an approximate 12-week period. And each of the sessions were videoed. They were randomized. They were, what's the word? We did, random fidelity checks on the videos that we took. And it was really just the most tremendous learning experience. It was sort of like Olympic training in Ayres Sensory Integration. And we were able to really take the just great mentoring and growth and education that we got in working with Dr. Roseann Schaaf and with ZOE. And we really just learned so much in this whole process. And what that really gave us as clinicians here at Children's, just such a strong foundation in Ayres Sensory Integration, an understanding of the process of taking it all the way from assessment to hypothesis, to understanding what pattern of sensory dysfunction we were talking about, honing our skill and understanding the neurophysiology behind that, and then taking it through to our interventions and the interventions that we were picking all the way out through the outcomes. It helped us really be able to speak in a common language in terms of Ayres Sensory Integration. And then we were able to take all of this information and continue it with staff training, organizing our staff training. We're a very large group of occupational therapists here at Children's. And Joanne Hunt, as Zoe mentioned, is our clinical lead. She leads an approximate army of 50 therapists, give or take. And we really then launched a very specific training for everyone across the organization, and we keep that up. So two things that sort of kept fine-tuning our skills, and that was analyzing the sessions that we were doing with the video. So we would watch the videos, and the word that came through was any missed opportunity. So we really worked on our observation skills so that we watched the videos and we looked for opportunities of where we could enhance what we were doing. Where could we grab another opportunity to get a little bit more intensity in the sensory experience, or a little more engagement from the child? So that was a great way to learn. The other thing that came out of working in this intensive sort of research project was the intensity of the therapy. So we were doing 3 times a week therapy for about 12 weeks, and we really shifted in our practice then post the research project to recommending more intensive type therapies to the clients that we were treating. So what I would like to do is segue now and show some video about the concept of capitalizing on an opportunity in a treatment session. This one. Hold on. Alrighty. So the first video is just a short one where within this session, started a little drumming and I decided to join on in, match a bit. And we had a little bit of fun doing that. He was having a little bit of fun looking at me, watching, and just grabbed that little bit of an opportunity to get a little extra tactile and proprioception. This. Okay, so let's look at another video. And I hope this is, yeah, this is the right one. So again, here I'm thinking about how I could join in on what my friend is already doing. He sort of gravitated towards the ball on the slide. In my head, I'm thinking, how can I get him to stick with this more? I made a very conscious decision to stop talking here so that my voice and the auditory system wasn't competing with his tactile experience and his proprioceptive experience. And I didn't want to interfere at all with keeping him on the task. So here I'm using a little bit more of like touch cues here to stick with. I was waiting and trying very much to be patient so he would continue with the engagement in this task. Sometimes I think it's hard for us to wait. This turn, I didn't really need to help. And so I felt like this was a good opportunity to have him engage for a bit of time there. And we got one more in there. Okay, so next, I'd like to play a video where the opportunity didn't go so well. And in this next video, we'll see a little bit about how some of our space can be a little bit of a barrier.
Here you go.
Oops. Okay. So just to set this video up a little bit, and we'll get a little bit more into this example when we expand the case a bit. But I changed up a little bit what we were doing a bit. In my head, I was thinking that I was providing an opportunity to expand a little bit on the praxis piece, but I lost them. As soon as it changed, and the postural demand and the I need to use my body a little differently came into play. I lost him in the task. So we'll build more on this conversation, but my clinical reasoning at this point was I was thinking, am I going to do more organizing and regulating, or am I going to switch over to try and expand more of the tactile and proprioception? But again, I'm trying to watch and see if he gives me anything to build on. So he wasn't quite ready yet to engage in something where we were going to get it sustained. So I had to do a little bit more work in the regulation department, and we eventually went back to the glider swing and worked there for a bit. Okay, so this sets up. So just to sort of finish the conversation of what we learned from participating in the RCT, we really were able to just grow our clinical skills, fine tune our clinical skills, and have the whole data-driven decision-making foundation and build from there. In a bit, we'll expand from the videos and take it into a very specific case and go from there. But I think that talking about Ayres Sensory Integration as an evidence-based intervention is super important. Let's see if I get this right. AOTA defines evidence-based practice as taking the solid information from the literature, combining it with our clinical expertise, and matching it up with the individual and the individual's, the things that are important to that individual. And so much work has gone into moving Ayres Sensory Integration to have such solid foundation in the literature. And I think that as the occupational therapists, the army of occupational therapists under this theory base, I think it's a good idea to keep pushing ourselves to communicate this concept of evidence-based practice in a way that families can understand, communicate it to physicians and other healthcare providers in a bit of a more scientific way, and then to continue to push ourselves to get out into the community. So we're sharing that information there as well. And I think we had a big win in the work that was done with the insurance company Cigna. If you just Google Cigna and Ayres Sensory Integration, it will pop up a really nice article. And in that article, Cigna is covering Ayres Sensory Integration as a billable situation. And within Cigna's communication of that, they very much define what it means for sensory integration. They deem it medically necessary for autism spectrum disorder. They list a subset of criteria, and they also mention the codes. So they use the CPT code 97533. It's defined as sensory integration techniques that enhance sensory processing and promote adaptive responses to environmental demands. It's a direct one-on-one intervention with the patient, and it is built in 15-minute increments, and it is combined with the ICD-10 code for autism disorder, which is F84. The significance, I think, one is that this large insurance company is covering Ayres Sensory Integration very specifically. It does match it up with the diagnosis of autism, and it also very much defines what they mean by that. And the literature review is quite extensive. That literature review may be a little difficult for some families to read, but then it'll be, sort of our responsibility as OTs to help them understand all of that. So, so I think a great amount of work is being done to communicate this concept of Ayres sensory integration and the evidence behind it, and that we'll just keep communicating that out in all the venues that we have the opportunity to do that. Okay, so I'd love to share a little bit more about my friend Tennessee that I work with, who was featured in the first couple of videos, and I have a few more to share as well. So Tennessee is 4 years, 10 months. He does have a diagnosis of autism. He lives with his mom. They love to go on hikes and play outside, and he loves stuffed animal toys. He always brings a friend with him to therapy, and we try to incorporate that in as much as possible. He goes to preschool and daycare. He's in an autism class within his school district in the town that he lives in. And let's talk a little bit more and get into the data-driven decision-making process as it relates to Tennessee. So we'll start with the assessment results. The assessment results that we have are the sensory processing measure, and he scored in the some problem range in these particular areas. He is a little over-responsive to sound. He is over-responsive to grooming, haircuts, food texture. He has some difficulty with feeding altogether. He is a mover and a shaker. He jumps a lot, pushes, pulls, chews on non-food items, has excess spinning and rocking and poor coordination. And then in the area of planning and ideas, he has difficulty with completing tasks with multiple steps, difficulty with imitation and song play, and then having trouble with coming up with new ideas for play and playing the same thing over and over again. The sensory processing measure results coincided very much so with clinical observations. And as an example, when he would try to get on the tire swing, he would often fall and run away. He doesn't really tolerate help in engaging with any of the equipment. So sometimes even the slightest trial of interacting with something ends up in a bit of frustration and a tantrum. And that all, is an example of really just how challenging praxis is for him. He often just sort of roams about for a while before he can start in with a task. And that's where it's a little bit difficult for me as I'm trying to nudge him along into an experience. But if I nudge too hard, then I lose him. He does tantrum. He tantrums on transition. He tantrums for mom a lot at home when things change or when their schedule is off or when they have to do something different. And sometimes he lets mom play with him, but sometimes he doesn't at all. And he does not like to eat new foods. So moving from the assessment information to the, as we call it, the ZOE table, also known as the sensory, I can't even get it right because I called the ZOE table so much. The sensory integration assessment interpretation tool. So we're moving into understanding the patterns that are most prominent from our assessment data. And the patterns that are most prominent for Tennessee really fall into the somatic praxis category and to the regulation part where he has a challenge modulating the tactile information, the auditory information, and even the vestibular information to some degree. So we're going to really try to hone in our treatment on regulating and organizing and increasing the intensity of the tactile and the proprioceptive input as best as we can. So a little summary, his participation challenges really are surrounding tantruming, eating new foods, sustaining play tasks, and playing with others or playing in new ways. We do have some strengths that we are able to build on in terms of he can do a lot of movement experiences and he can hold his body weight. He's beginning to vocalize more and get some reciprocal voicing. He doesn't, when he first started with me, he didn't really say any words. And you could even see a bit in the video where some words are coming out in, you know, he's not mimicking, he's actually initiating the use of some words. And we try to build on playing with the toys that he brings to therapy. So we're going to go through with 2 examples of intervention and 2 goals. The first goal that we have is really looking at improving regulation and praxis so that he could expand on a few new play ideas that are introduced by mom and, you know, be able to play with mom in a way that doesn't elicit a tantrum or an escape behavior. We're going to try to use some linear movement activities and a lot of like voicing and singing to help him organize, and then bring in more of the tactile play and the proprioceptive play to, you know, really hone in on that somatopraxis experience, and then see if we could get him engaged for a little longer in these tasks so that we could build on slightly adding some praxis challenges. So let's take a look at another video for Tennessee and see how we did that. Okay, let's see here. Okay, so I'm going to go ahead and play this video. So right prior to this in the treatment session, he engaged in the glider swing and we stuck with that glider swing and we were singing back and forth. So, and we did that for about 15 minutes. And that sort of set us up for this play exchange.
Gina.
So I feel like I learned from the first time to be a little quiet here and let him enjoy this sensory experience and let him decide when it was going to be over. Then had a little cueing and a little voicing reciprocation here. Building a little bit on the anticipation phase. And what we were then able to do is we were able to keep going with that for a few rounds to just increase the intensity of that tactile and proprioceptive play. And I think that's one of the keys in terms of the thinking and the reasoning is getting that balance back and forth between how much time you have to spend in the regulation phase and how much time you're then building onto a second pattern that you're working in. So if you're working with multiple patterns, how you take that balance and clinically reason that through within a session and when to sort of go back and forth between those two things. So in working with Tennessee and other children with autism, I feel like that's one of the things that we have to hone in on a bit and plan for and think about in our sessions. So taking it to goal number 2, Tennessee came through our feeding team. And here at Children's Specialized, we have about 10 to 12 feeding team evaluations that are done with a multidisciplinary approach. We have occupational therapy, speech therapy, nutrition, and psychology all on our team. And we use a system approach to do this evaluation. And we really sort of try to peel away the underlying components as to why a child has some feeding challenges, and then recommend the package of therapy that fits. Very often, when the children have a diagnosis of autism, occupational therapy is part of that mix. And very often we have to do a lot of preparatory work in our treatment plan to then be able to then get to work on the feeding component. So that's pretty much what Tennessee and I are doing, trying to improve some of the foundational sensory integration challenges so that we could build him up to be able to sit for mealtime and begin to engage with a tactile system that's a little bit more organized and a overall regulation that's a little bit more organized, so that even the slightest new thing doesn't sort of topple over his apple cart. So this goal is very much surrounding feeding, and in the beginning, just tolerating engaging with mom at mealtime, and tolerating some of the his non-preferred foods in his space, and to begin to interact with that with mom. So the treatment planning is very similar to the previous goal, but we're honing in a little bit more on getting a little bit more of that regulation piece, and a little bit more of the task persistence, a little bit more of the engagement, so that when we transition to sitting at the table for meals, he's ready to build on some of those things that we do in the bigger and gym environment. Okay, so I have one more video to show. Sorry, give me 1 second. Here it is.
Boom, Gina. Boom. Boom. Again, come on.
So this turtle has a little bit of weight to it.
Come on.
He very much is attracted to it.
No, boom. Boom. Or roll. Here I come. Here I come.
In this video, you
Here
can
I
sort of see where
come.
some of my competition in the room is a little challenging.
Here I come. Come on, you too. Turtle up. Turtle up, turtle up, turtle up. Here I come, turtle. Ugh. Ugh.
So here I'm just sort of waiting and watching and seeing if he's going to stick with, if there's something else I need to join in with him, or if I just need to give him a minute
Here I come.
to then come on back.
Here I come.
And he's starting to a little bit anticipate what I'm doing, and
Here I come.
he's having sort of a good time, and he's rejoining me. And I think that's the adaptive response here that I'm looking for, is him rejoining me in the play. And if I can do what I need to do to help engage him longer and more intensely in the sensory experience. So the good news is, relative to my story with my friend Tennessee, is that as I continue to treat him, I'm able to get more and more of the intensity and the sensory experience with the other pieces of equipment in subsequent sessions, like the Lycra rainbow swing, like the trapeze bar, like the Lycra tunnel. And we just continue to build on all of that. And I'm happy to say that he's starting to engage in using some pictures to communicate with mom during mealtime. They do a great sharing experience of mom having a turn, giving him a picture, and he's sharing his veggie straws with her, and vice versa. Then he gives her a picture and she shares, and we're really building on that engagement. And recently we took this toy out. I set it up, but he figured out how to get the rocket on top. And after one just visual demonstration, he figured out how to make it work, and he stayed playing for a longer time than he ever has before. So it's a lot of fun stuff in working with him. And again, I think that in working with children with autism, we're always need to sort of push ourselves to see how we can use all of the parameters of Ayres Sensory Integration to build the foundation for them, so that they can continue to just build on playing and interacting and vocalizing. And we have just so much opportunity to grab some of these adaptive responses. And there are also challenges. So it is helpful to, if you can, get a video of a session and then build your clinical reasoning with analyzing that video. If you don't have the opportunity to do the video, you just think back sort of on your session and you're asking some of these questions. Did my hypothesis hold up? Is it matching what I'm currently seeing? Am I working with more than one sensory pattern? And if so, did I get the just right balance back and forth? Do I need to spend a little more time here or build more on an opportunity there? Did I take enough time to watch and see what the child was offering to me? Did I capitalize on my opportunities? Do I have to change the environment up? And what do I need to do to adjust what I'm doing? And then, also just taking that time to watch what the child was doing. So again, just some highlights relative to working with Tennessee. I'm constantly in the session thinking to myself, am I choosing activities in the moment that are helping me facilitate regulation? And did I get that at a good enough intensity for me to then switch into trying to help him experience it more tactile and proprioceptive experiences? And then can I use myself and the environment to offer the just right challenge for those praxis experiences? Am I following his lead? Can I join in enough? And can I can I set it up so that the praxis challenge is, sort of downgraded enough so that he could feel successful within it. So those are my biggest things that I'm pushing myself to think through while I'm treating Tennessee and other kids like him. So this is just my little slide on building those opportunities. Continue to look and listen, continue to wait for that extra pause of a second to see what the child is gonna give you as far as information so that you could build on that engagement and get that next adaptive response. I always say, do your best to spend some time not talking, and you end up learning a lot in those pauses. And then my next slide is just a little bit of a thinking through the child's eyes and expanding on that. So, in this sensory experience, they're getting the opportunity for that praxis and play, and we're trying really hard to hit that just right challenge. So from their eyes, they're feeling more, they're doing more, and we're setting it up for them to do it again and again, and they want to join in, they want to say me too. And I think a lot of the kids with the praxis challenges, it's not that they don't want to play with us, they want to, they just can't figure out how to. And so all of this experience just builds into their ability to join in and play with us, that engagement of understanding each other, and then just continuing to build that relationship. And then they want to do it more and more and more. And then they get so much practice with it. And then, they move into the point from I don't know how to, I definitely know how, and I want to do it more and more and more. And I think that that's just the funnest part of our job, when you can see that transmission for the kids that we work with. So that segues into the last topic to talk about, which is documentation. So in our hospital setting, we bill insurance companies, and our documentation needs to hold up so that they pay for our services. And the things that we need to think about in documentation is, what intervention did we provide? Did our documentation demonstrate our skilled care? What were the responses that the child had, and how did we connect that to their function? When we do documentation, and we train our staff to do documentation, we try to not talk about necessarily what tasks we did or what pieces of equipment we did, but to target a little bit more as to what sensory system we were looking at facilitating, and how are we going to quantify that in some way, whether it be in time, intensity, on how we could sort of like put in some of that measurability, and then try to just describe some of that a little bit more and connect that all the way through to the participation piece. So I just then would like to go through a quick example of a SOAP note for something that would be like the treatment session that we saw clips of in the video. Here at Children's, we have an electronic medical record, and we have a template that's fairly extensive, but the bottom line is we're writing SOAP notes. And so this is just a quick down and dirty example of a SOAP note, what mom reported, some tantrum behavior before the session. And in the O section, I tried to connect the sensory input to a measurable component like time, and talk about how we moved from regulation to somatopraxis, and how that was important because we were looking to sustain play engagement. In the A, really trying to talk to the adaptive responses that we saw, and then pair them with some of the goals that we're working on. So I tried to note that he spent a longer time in a play scheme. I tried to note the engagement that he had with me. That was an improvement from the past where he was voicing more. He's now went from not saying any words to saying 2 words at a clip, and trying to document the intensity relative to some of the play that he did during the session. And then to also say that we still have some work to do in the praxis area, and set that up for the plan as to the fact that we need to continue to expand his sensory experiences so that we could build through the regulation piece and the praxis piece, so that we're making some positive changes for play and mealtime participation. So that is my version of the case for Tennessee. And I'm gonna open it up for any of the questions. I'm not sure how to do that.
Well, Gina, that was beautiful.
Thank you.
Stop share.
Okay, I'm gonna stop share here. And I'm more than happy to join in with the others and figure out how to take some questions or talk through anything that anybody brought up.
You know, I know there's questions. I have a quick question just to kind of start at the beginning in terms of the referrals. I know you said some of the way you get your referrals is because of the feeding issues, but I'm curious because you're opening 3 new centers. Is it because you're so successful? Is it because there's more children being referred? I mean, how are you getting so many more kids?
So I will say, so we're actually getting new buildings. So it's the same center, but we're just getting a new building, which is super exciting. But so we have 13 outpatient sites, give or take. You might take a couple away because one's an inpatient site. Anyway, at any given time in Toms River, I've worked here for 20 years. I've had 50 kids on the waiting list for 20 years. Referrals are not a problem. We have, so I think it's a good question though, to expand a little bit. We not only have therapies at Children's Specialized Hospital, but we also have neurodevelopmental pediatricians. So we partner up very much so with our physicians. So we may get referrals from outside pediatricians, but we also get referrals from our neurodevelopmental pediatricians, our physiatrists, and nurse practitioners. And that the combination of the physician referrals drives the kids who come in to see us.
Okay, thank you.
You know, I just want to add a thank you again. You know, you all, this team, Joanne, Patty, Gina, Elka, you have done so much for so many children and families by your openness. You probably, all of our attendees can probably tell how humble and open this team is to considering when things aren't going well and to being open to suggestions. And that openness has led to, you know, just amazing results. We can see why the therapy you provided was so effective and demonstrated such strong evidence, which, you know, leads to things like Ayres SI being recognized as an evidence-based approach, having insurance reimbursers pay for it. It's just, I hope you recognize your contributions. It's really amazing.
Well, thank you. Thank you. It's our pleasure. We love doing this. We love working together and working with all of you. And just, you know, we're just committed to keeping on and expanding this. And, you know, and the most important part, which is working with the child who we have in front of us and helping the parents see the potential that they have and giving them, you know, giving them that glimmer that their child can do, and just build on that.
Well,
That's nice. I think we're
we're
out of
about out of time. I
time.
don't know if Joanne or Patty, if you have anything you would like to add here at the end, where the time goes by so fast. These are like spa treatments or something. It feels so good getting to gather
know.
this way and see that beautiful treatment. But Joanne, Patty, do you have anything you'd like to say?
Yeah, it is, Gina. That was a fantastic presentation. And you are right, spot on, Zoe, when you say that Gina is a master clinician, because she is. But we're so grateful of the relationship that we've been able to develop with all of you, and all of the mentoring that you've been able to provide us. So that's just priceless for us.
And I'll
Okay.
chime in. I agree. I know nobody can see me for some reason, but Gina, you did an amazing job. I love our team, and I love how we've had opportunities that you just don't get everywhere. And it's expanded that Gina's working on starting another research project. And we're just continuing to work with Zoe and Suzanne and Roseann to continue ourselves learning, but to get more evidence out there. And it's just such a strong partnership. We've really, as a children specialized, really taken hold of the data-driven decision-making model. We use it with our students. We use it with new interns. It's constantly being used in our departments. And it's just because of the relationship we've been able to do. And we just feel so strongly about it.
Yeah, everybody has a ZOE table at their desk at the ready.
It's not my table. That's everyone's.
I was at the Newark location last Friday, and all of the OT desks had the ZOE table up.
So silly.
That's important. That will really help your clinical reasoning for sure.
So we have a raffle, right? Before everybody leaves, we're at our time, I think.
We do. And so who has that? Marco, Melissa, who has the names for the raffle?
I do have that.
All right. Yay.
And I can turn my camera on because Zoom is not leaving anyone turning their cameras on today. So, but I have the winners, and that's the important piece. Yeah, so should we go first with the Easy Starter Kit, or?
Yes, let's do it.
That? Okay, so Easy Starter Kit. The winner is Natasha Montava. And I hope you can see my screen. Natasha, congratulations.
We can see it, Marco.
Yes, we can. Thank you.
Okay.
Congratulations, Natasha.
Congratulations. We'll be leaving Melissa Coleman email, so you can email her and to get all the details to get your Easy Starter Kit. And now for the SATPA equipment, the winner is Shannon Corcoran. And I hope I said this right. Congratulations, Shannon.
Yay.
Hey, that's so great.
Shannon.
I just posted Melissa email on the chat, so you can both reach to Melissa. Congratulations.
Thank you, Marco. And so, Suzanne, are you going to tell us about next month, Treatment Tuesday?
Yes, I'm all ready now. Yes. And I'm very excited. Thank you guys so much again. Okay, so coming up in September, on September 14th, we're going to be back in school, and we thought it was a good month to talk about Ayres Sensory Integration in schools. And we have Lisa Test, who is the coordinator of programs at Los Angeles Unified. She's been doing it for years and years. And then also Tracy Cooper from Ohio, and she's a friend of Southpaw, and she's also very experienced, from the Midwest, to see the different ways that sensory integration is being used in school-based practice. In October 12th, we will have Sarah Sawyer, who is the program director at the Kumar Center, and also Jenny Peterson, who's a university faculty and one of our dear colleagues, and they're going to talk about how to build master clinicians. And so what they do to support from a fieldwork level, but also on a practice level. In November 9th, we're going to have two, well, everybody's amazing, but these guys are really amazing. So Dr. Margaret Bowman, who's an eminent neurologist, and Isabel Beaudry, and they're going to talk about health and including toileting habits in our kids, you know, especially with autism. And then last but not least, in December, we're going to talk about wellness, but coming from a trauma and attachment perspective. And Dr. Tina Champagne will be with us that day. So, and that'll be it. We'll end our 2021 webinar series that way. And I think it's a wonderful lineup, but we will let you know. We'll put the ads out in advance so that you know, and I hope that everybody can join us for all of them. And if not in person, they will be recorded.
Thank you again, Gina and Joanne and Patty and our classy team and Suzanne for your amazing vision on this. So thanks to all and stay well. We hope to gather again in person soon.
All right. Take care, everybody.
Safe
Bye-bye.
travels, Marco. We'll miss
Thank
you.
you.
Bye.
Bye,
Thanks,
everybody.
Bye-bye.
Bye.
Bye.